My name is Tran, and I am a family nurse practitioner. I graduated in 2020 from Merritt University. Then I decided to obtain my DNP degree as a terminal degree in nursing right after I graduated, with the goal of continue to provide the highest quality of patient care. I would like to take a moment to acknowledge and thank you, all of my SMU professors who have supported me throughout this DNP journey, and a special thanks to my project chair, Dr. Fomento. Thank you for your continuous support and guidance throughout this project. Also, I would like to thank my husband, my family, my friends, and the staff at the clinic where I did my QI project for their love and support. Thank you all for assisting me in reaching this milestone in my academic career. Today, I want to share with you my poster project regarding hypertension management. My DNP project is titled A Quality Improvement Project to Improve Hypertension Management Among Vietnamese Adults in Primary Care Setting. Since graduating from the DNP program in 2020, I have worked at this primary care clinic. This is the same clinic where I did my clinical rotation while in the DNP program. This clinic specializes in primary care, and it is a multilingual office. The clinic provides comprehensive primary care services for diverse population. However, most patients are Vietnamese. Over the past year, I have noted that many Vietnamese patients at this clinic have a diagnosis of hypertension. However, the blood pressure was suboptimal due to non-adherence to hypertension treatment plans. Therefore, I thought it was crucial to find strategy to raise awareness and address the importance of reaching a target blood pressure to prevent stroke and heart attack. This idea led me to this QI project to teach patients what they could do to improve their blood pressure. Before I talk more about my project, I would like to provide some background regarding hypertension. Hypertension is associated with life-threatening diseases. Indeed, hypertension is considered a silent killer, affecting more than 100 million people in the United States. Approximately 30% of American adults are hypertensive. The literature showed that approximately 1/2 of hypertensive adults in the United States have uncontrolled blood pressure. Likewise, uncontrolled blood pressure also affects the Asian American population in the US and could lead to heart disease, kidney disease, and stroke. Although there are known risk factors associated with uncontrolled blood pressure, adherence to antihypertensive treatment remains problematic worldwide. Indeed, in a longitudinal study comprised of 4,783 patients, it was noted that half had stopped taking antihypertensive medication within 1 year of treatment. Unfortunately, hypertension affects everyone and increases with age. According to a study from 2015 to 2016, the prevalence of hypertension in the United States was highest among the age group of 60 and over at 63.1%, followed by age group of 40 to 59 at 33.2%, and lowest among the age group of 18 to 39 at 7.5%. Studies have shown that those with uncontrolled blood pressure who can lower their blood pressure by 10/5 mmHg can significantly reduce the risk of cardiac event by 22% and stroke risk by 41% in a 5-year period. To improve the management of high blood pressure in adults, the 2017 ACC/AHA guideline recommend a target blood pressure of less than 130/80 mmHg for those with hypertension. In addition, this guideline also recommends hypertensive patients to follow the dietary approach to stop hypertension known as the DASH diet. The DASH diets include fruit and vegetable, whole grain, low sodium, low fat protein, which has been an effective dietary intervention to lower blood pressure and promote cardiovascular health. The literature showed that cultural and language barriers are among the major impediment to preventing and managing hypertension among Asian Americans. Furthermore, the literature showed that some Vietnamese patients do not fully understand the cause and prevention of hypertension due to low health literacy. Thus, providing cultural appropriate therapeutic patient education will improve patient understanding of hypertension management. Therefore, my improvement project was to provide an evidence-based education program with cultural modification to improve hypertension management. The clinical question proposed for my DNP project is, in Vietnamese adult patient greater than 50 years of age at a local primary care clinic, how does the implementation of high blood pressure education using the AHA hypertension guideline toolkit with cultural modification compare with standard of care without cultural modification in improving adherence to antihypertensive treatment, blood pressure, and BMI in 3-month period? The cultural modification in this project include providing teaching material in the Vietnamese language to facilitate understanding, since most patients do not speak fluent English. Before the intervention phase, I had generated the required resources, such as creating a home blood pressure log, an educational PowerPoint presentation, a hypertension educational brochure, and a pre-test and post-test using the Hilborn compliance scale. All of the teaching material were translated from English to Vietnamese. Now I will summarize the method and result of this project. The setting for this project was at a primary care clinic located in Chandler, Arizona. With the help of the office staff, I recruited a convenient sample of 24 Vietnamese adult participants and completed this project over 3 months. The outcome was measured using the relationship between the pre-test and the post-test score from the Hilborn compliance scale and comparing the baseline and follow-up data from the blood pressure and BMI result. The Hilborn high blood pressure compliance scale is one of the most popular scales to assess hypertensive patient adherence behavior. The psychometric property of this tool has been utilized by many healthcare professionals in several countries and were found suitable for primary care setting to improve treatment adherence and health outcome. The Hilborn high blood pressure compliance scale was constructed using the Likert scaling model. The total score ran from the lowest 14 to the highest 56, which was divided into 3 subscales: medicine compliant, sodium intake, and appointment keeping. Statistical analysis were conducted using the IBM SPSS statistical packet. All p-values were two-sided with statistical significance level of 0.05. From December 1st, 2021 to March 26, 2022, a total of 24 patients with a current hypertension diagnosis were recruited for this improvement project. The mean SD average age for this project was 67.67 years old. The oldest was 66 years old. The oldest was 86 years old and the youngest was 52 years old. All 24 participants were identified as Vietnamese immigrants living in the US. All participants completed the pre and post test for the Hilborn high blood pressure compliance scale and attended 3 educational sessions. A paired t-test was performed to compare the result to determine whether there is a significant differences between the pre-intervention and post-intervention score. A level of significance of 0.05 was used in the analysis, which means if the p-value is smaller than 0.05, then there is a significant effect. Correlation between changes in the test score were explored. Based on the data analysis, there appeared to be a significant positive relationship between the pre-test and post-test score for sodium use, appointment keeping, and medicine compliance. Data also showed a significant positive relationship between the pre-test and post-test score for systolic blood pressure, diastolic blood pressure, and BMI measurement. This quality improvement project sought to evaluate a cultural adapted hypertension education approach tailored to improve patient knowledge and adherence to hypertension management in order to reduce health burden, mortality, mobility caused by uncontrolled hypertension. The result demonstrated that providing educational guidance based on the AHA high blood pressure toolkit with cultural modification do improve hypertension management among Vietnamese adults in primary care setting. The data demonstrate a significant positive relationship between the pre-test and post-test score for sodium use, appointment keeping, medicine compliant blood pressure, and BMI. While completing the project, I have noted that the participants were thankful for the hypertension education and the material given in the Vietnamese language. Some patients told me that they sometimes stop taking their blood pressure medication when they don't feel well, or they share their medicine with others. In addition, they didn't know that certain Vietnamese food items, such as instant noodle, contain high amount of sodium. Some say that they eat instant noodle daily because it was cheap and convenient for them. With the information provided in this QI project, the participant learned to combine anti-hypertensive medication along with non-pharmacologist intervention, such as weight loss for healthy BMI, healthy diet, such as following the DASH diets, increased physical activity, limiting excessive alcohol consumption, avoiding smoking, and incorporating stress management to improve blood pressure outcome, which was the goal of this project. A limitation for this project was the small number of participants. The sample size and data were restricted to a small clinic in Chandler, Arizona. Another limitation was that the intervention was implemented over a period of only 12 weeks. Therefore, there is a lack of evidence for long-term inference and increased potential for bias. I think that a larger setting, larger practice, or including more clinic sites would have increased the sample size, would have been more helpful in determining the effectiveness of this project. This improvement project does show promising results. Providing cultural education teaching can improve patient awareness of hypertension management and health outcome. Since hypertension contributes significantly to developing chronic condition, advanced practice nurses can implement evidence-based programs that tailor educational intervention model to help decrease cardiovascular disease associated with uncontrolled hypertension. This technique can positively impact hypertension management, thus improving health quality, cost, and patient outcome. To improve hypertension management and retain this QI project sustainability, I encourage the office staff, mainly the manager and the provider, to continue providing culturally appropriate intervention by acknowledging and sharing toolkit. Also, I have continued to provide teaching based on the brochure and provide handout for my hypertensive patient at the clinic. In addition, I have emphasized that it would behoove the clinic to embed this intervention, since it will reduce the rate of missed follow-up visit and generate income from the increased daily visit. In conclusion, treating high blood pressure is vital to improving the quality of life for all. Therefore, removing the barrier that could impede treatment compliance for hypertension management would likely lead to successful outcome. This improvement project overall goal is to facilitate change to improve patient outcome, enhance quality care, and decrease mobility and mortality rate associated with uncontrolled hypertension. I believe that providing cultural sensitivity and addressing barriers that could impede treatment compliance among Vietnamese adult patients would likely lead to successful outcome, decreased cardiovascular disease, and thus reducing costly disability consequences. I appreciate everyone for being here today, and thank you so much for your time. I'm happy to answer any question you may have. Thank you.
Thank you, Dan. Excellent, excellent presentation and project. I would like to open to questions.
Thank you so much.
I have a question. Well, first off, great job. You did a
Thank you.
wonderful, as I expected.
Thank you.
You know, I guess it seems obvious, not obvious, that, you know, all the people need to have education that's in their language, that is, you know, modified and to their culture, and in order to be successful in managing their chronic condition. But so I guess my question is, what was the biggest barrier? Because it seemed that you kind of whizzed through everything and there wasn't really, we didn't experience too many challenges, but I'm just wondering now, looking back, what was the biggest challenge in your implementation?
The biggest challenge in my implementation is the time that I spent translating the material into the Vietnamese language. And also some of the Vietnamese patients, the older they get, it's hard for them to change. So education and spending the time to explain the benefit of following the blood pressure management to improve cardiovascular outcome will behoove them in the future. So the challenge of my project, which is a lot of time consuming, even though it was 3 educational sessions, I have provided the extra time to provide the additional guideline and support to help them maintain the blood pressure and following their management.
So do you see this as being sustainable in your clinic?
So far, since I provided the QI project, when they come back, I see that their blood pressure has improved. We also had implemented a program, the RPM program for hypertension, and I currently manage them too. I see their blood pressure log as they log in. And then if it was higher or something, I will call them and follow up with them to see what's causing that. But so far, it seemed like those patients that were in my project, it seemed like the blood pressure was stable. And I think maybe because they understand how to take the blood pressure correctly now, and maybe with lifestyle modification, the BMI is optimal, blood pressure was good. Thank you.
Well, you're welcome. Well, I guess, you know, the way I see this is, you know, in your clinic, when you have a condition or a prevalent, you know, a priority condition or a prevalent condition, whether it be hypertension, diabetes, high cholesterol, just to name a few, you know, now you see the value in having the culturally modified education and support. So, you know, you've now shown that you've provided evidence to support the
Yes.
time and the money investment in that, and that there is going to be a return on that investment.
Yes, I hope so. I'm trying my best to provide the best care that I can.
Yes, you have a lot of work ahead of you. And we're looking forward to hearing about it. I'm looking forward to hearing about it as you move forward.
Thank you.
You're welcome.
Excellent.
Thank you.
Any other questions for Van on this great project? So, of course, as we all know, making sure that patients understand our communication and having it in their primary language is really critical to our outcomes. So thank you so much for bringing this great project forward. And I do look forward to your dissemination and other outcomes as we continue to move forward.
Thank you so much, Dr. Well.